Hi guys, it's Professor Costa and I'm back with impaired cerebral perfusion, acute phase part 2. All right, so in our prior video, we discussed risk factors and the types of strokes and things like that. Now we're going to talk about rapid focus assessment to identify a stroke. So the pre-hospital providers begin with the assessment BFAST. I did put this picture up separately in Blackboard, so you'll see just a JPEG with this a slide that says BFAST. The NIH, the stroke scale, or a mini NIH stroke scale. All right. So if this patient is in the emergency department or in the hospital, you'll hear code stroke called, and that's so that the team understands that time is brain, and we need to rapidly assess and work this patient up. And that includes things like diagnostic imaging. So they would hold the CT scanner, for instance, from a routine CT, and they would hold that and keep it available for the patient with a stroke. Focus assessment of blood glucose. So remember that sometimes patients appear maybe just confused or dizzy or weak, and we want to differentiate that. Perhaps they're diabetic and they're hypoglycemic. So a good workup an initial workup would include a blood glucose level, right? We don't want to confuse hypoglycemia for an acute stroke. The exact time of onset. When did this happen? Or do we know their last known well? All right. A quick history of the timing of the event, pertinent past medical history and risk factors. You know, for instance, if you found out that this patient had a stroke in the past or has atrial fibrillation, that would be pertinent medical history. And we want to do a full stroke scale, right? The NIH stroke scale can also help guide the assessment. So components of the NIH stroke scale would be level of consciousness, best gaze, visual, do they have blurred vision, or are they missing half the picture? Or is the gaze deviating to one side or the other? Facial palsy, do we have any areas of the face that aren't moving? Arm motor response, can they hold the arm up? Can they keep the arm up to pressure? You know, if we push down, can they keep their arm up? Leg motor response. Limb ataxia, is everything moving normally, or is there one side not moving? Or is it moving weirdly, stiffly? Sensory, can they feel can they feel everything? Is there any numbness or tingling anywhere? Their best language, dysarthria or neglect. So possible diagnostic tests associated with stroke would be that blood glucose, a CBC, right? Electrolyte panel, cardiac enzymes, right? Is this accompanied by acute coronary syndrome, for instance? Or is it acute coronary syndrome causing decreased blood flow, which is then mimicking a stroke? PT-INR, so definitely that blue tube, we want to do coags, right? We want to make sure that this patient doesn't already have a huge high INR, and then we would complicate things by adding a clot buster to that. We want to get a non-contrast CT, right? And it's really key that this gets done. We also want to determine that, is it an ischemic stroke or a hemorrhagic stroke? So is there a bleed evident on the CAT scan? In many cases, an ischemic stroke, the CAT scan is going to appear normal in the first phase of this. A cerebral angiography, so we may be able to map the blood vessels and see what's going on, and maybe even pinpoint the area of blockage, right? An ECG, an MRI, a carotid duplex, that's where they do like the ultrasound of your carotid arteries. Maybe they can see a huge area of plaque that's been breaking off. And an echocardiogram. This is not all done before the stroke diagnosis is made, by the way. So maybe you had a TIA and you dodged a bullet there, and now they want to figure out where the possible cause of that. So they may do an echo. So for further classification of ischemic stroke, we have the TIA, which is that transient ischemic attack. So that's something that shows up and then goes away. All right. We have the actual acute ischemic stroke, which unfortunately doesn't The signs don't dissipate, and we definitely need to intervene in a hurry. And then we have the big one. This is the big and baddie, right? Is the emergent large vessel occlusion, or ELVO. All right, more on that later. Okay. So, what is an ELVO? It's the most devastating ischemic stroke. It's a blockage of one or more of the main arteries of the neck and brain. So, the ICA, the MCA, the vertebral artery, or the basilar artery. So these are big vessels, right? These are like the I-95s, and we don't want to block that, right? So the arteries involved in an ELVO perfuse a large portion of the brain, right? So obviously, if we have a huge section of the brain that is being deprived of blood flow, that's why these are associated with high morbidity and mortality, right? 30 to 40% of ischemic strokes are considered ELVOs. So that shows you the scope of the problem here. We don't want 95 shut down. We want blood flow to our brain. We want to keep that open as long as possible. All right. So diagnosing an ELVO stroke. Time is brain. All right. Rapid evaluation of the patient. It's paramount. Now, why is getting the patient to VIR as soon as possible critical? I don't know. It's been a while since I've taught 1020, but the new emerging data is that for an ischemic stroke, in addition to administration of TPA, right? Or if a patient is not a candidate for TPA, we can bring them to VIR, which is that interventional radiology department. And we figured out that for these big strokes, that the big vessels, that we can actually go through interventional radiology, insert a catheter into a large vessel, right? Snake the catheter up to the area of occlusion, and we can actually remove the clot, physically remove the clot. So the best practice currently for an ischemic stroke would be the combo. If the patient can tolerate TPA, we administer TPA, and then we also want to bring them to VIR, because we've realized that, yes, we may have gotten rid of the platelet party, so to speak, at the area of plaque. But if it's plaque, then just like acute coronary syndrome, we want to get up there and physically remove the obstruction, because TPA isn't going to get rid of the plaque. It'll get rid of a clot that forms around the plaque, but it may not get rid of the whole problem. So getting the patient to VIR as soon as possible is critical. So the chance of obtaining a good outcome decreases by 15% every hour the process is delayed. And that's directly from the director of the Neurovascular Center at Rhode Island Hospital, right? So this is current local practice. So remember, patient may be treated with both TPA and a thrombectomy, that going to VIR, all right? So that's the current recommendation now. And these things change all the time. I don't know, in 6 months, they may have a new recommendation. So this is current latest practice. So how is an ELVO diagnosed? In the pre-hospital setting, so EMS, so the people that are picking these patients up at the scene do also get continual education. So they've been taught that if they're suspecting an ELVO, that they need to get that patient to an area, to a hospital that can not only give TPA, but that can also do a thrombectomy. So Rhode Island EMS uses the Los Angeles, sorry about the spelling, motor scale, the LAMS, to determine if the patient is having an ELVO or hemorrhagic stroke. The LAMS scale goes from 0 to 5 based on the signs and symptoms the patient is having. Remember, this is pre-hospital. This is out in the field. So based on the score, patients will go to the closest primary stroke center or can be diverted to a comprehensive stroke center like Rhode Island Hospital if the score indicates an ELVO or hemorrhage. So if you look at the scale itself, so a 0 would be both sides move normally, a 1 would be one side is weak or flaccid, right? Arm, both sides move normally, or one side is weak, or one side is flaccid or doesn't move. You can see how this works. So 0 to 3 would be, it's considered a mild stroke, and then they could go to a primary stroke center, right? So they could go to Kent Hospital, for instance. 4 to 5, we're now looking at a more serious stroke, It indicates that the patient is having a severe stroke and should be sent directly to Rhode Island Hospital. So an area EMS receive education on this, recognizing a stroke and performing the LAMS exam to patients in the field. We're fortunate. We have a comprehensive stroke center at Rhode Island Hospital. We have multiple primary stroke centers in the state, so you don't have to wait hours to be transported somewhere, like in parts of the country where hospitals are spread out. We're very fortunate to have great places where we can be brought if we have one of these events. So ELVO, the 60-second clinical exam, right? And this is adopted. This is training that they received at Rhode Island Hospital. So we borrowed it. We want to look at the patient's eyes. Are they deviated to one side? Can they look all the way on both sides? So with an ELVO stroke, the patient's eyes are turned away from the side of the body that is weak. So their eyes tend to look towards the good side. So are they deviated? Can they look right at you? Can they look back and forth? Can they follow your finger? Okay. Ask the patient a question. All right. So how old are you? What month is it? And it tests listening and speaking. Okay. And it's more pronounced in the dominant hemisphere. So usually the left ICA or MCA stroke would have more issues with listening and speaking. We want to check their motor function, right? So we want to look for anti-gravity strength in the arm and leg, right? So can they keep it up? And if I push on it, can they keep it up? I have really poor core muscles in my, so I don't know how I'll do if I ever have a stroke, keeping my leg up, just like, ugh, you gotta have some core strength there. And we want to look for that facial droop. We want to examine them for neglect and hold their hand up. Whose hand is this? While showing them their left hand. And this is usually more prominent with right MCA occlusion, right? They may not recognize that that's their hand, which is really freaky. We want to check their visual fields. So we want to examine for a blink on both sides, and they can get fooled by neglect in the right MCA, right? You want to consider that patients with large hemispheric strokes are, sleepy. It's hard to keep them in the exam, and so they may not be able to cooperate with the entire thing. So how is it diagnosed? In addition to the physical exam, and we're not the only ones. The nurses obviously are not the only ones doing this exam. We're going to have a neurologist, but we also have to recognize changes. Things happen very quickly. We have to recognize those changes and report them, okay? In addition to the physical exam, they're going to need a CAT scan, right? And they may also get a computed tomography angiogram, and that one utilizes contrast. So a regular CT is done without contrast, but they may also need a CTA. And that's what they're doing right now at Rhode Island Hospital for their code strokes. They want to see if they can see the map and pinpoint the area so that they can see if it would benefit from a thrombectomy, or if it's, in an area where it would be amenable to thrombectomy. So this allows for visualization of the vessels in the brain and neck, and it can help determine if they're having an ELVO or a hemorrhagic stroke, right? Again, and also determine if the clot is amenable to endovascular treatment in VIR. Can they roto-rooter that bad boy out?